about 3 hours giving you a lecture on insurance. As you know, health insurance is a very big topic these days. There's a lot of pros and cons to it, and as you might hear from my voice, I grew up in London, England, and I was subject to the National Healthcare Service, which I will not care to elaborate on today. Anyway, we do own an insurance agency in downtown Redwood City, and we do handle all aspects of insurance, but we do specialize in employer group plans and individual health coverage, and also Medicare supplement plans. So I'm going to try and give you an overview in the time that I have of the different types of insurance coverage that you can and might have, and also where those different types of plans might fit in to various stages of kidney disease. As Brad said, I am chair currently of the Hospital Foundation Board here, so I spend a lot of time in my office upstairs. I have a challenge of raising $20 million in the next 2 years towards the rebuild of the hospital. So I either need 20 million people to give me $1 or 20 people to give me a $1 million check each. Either way, I don't care. I just need to get it done. It's a very time-consuming project. Obviously, there are numerous companies out there. There are numerous insurance plans, and so we cannot review all the specifics of all of them today. I'll be pleased to answer any questions you might have specifically on, your individual situation afterwards when we get into questions and answers. Other than Medicare, which we're going to deal with a little bit later with Christine as a separate issue, there are basically 2 types of insurance plans you're dealing with. You either have coverage that's been provided through your employer, through a group plan, or you have coverage that you've purchased yourself as an individual. A very generalized comment is that typically group coverage can be a little bit richer in its benefits, in what it provides to you, and also your employer is probably paying part or all of the premium. Whereas an individual plan usually is going to have higher deductibles, it's going to have higher what we call co-pays, and you're going to pay the entire premium for that coverage. The other main difference is if you are eligible for an employer group, then you have to be accepted by the insurance company regardless of your medical history. Most companies, whether they are group or individual, are going to offer you both HMO and PPO options. And I have put an insert into your packets which gives you the basic features of an HMO, a PPO, and then today what's also becoming very popular, what's called a health savings plan, which you will see in there. And so if there's questions on those a little later, I will go through it now in the interest of time, but it does kind of give you a synopsis of the differences there. So HMOs are going to offer you good coverage in that the co-pays for office visits, tests, hospitalization are typically low for the patient. However, there are restrictions in terms of which hospitals you can use, which clinics, which dialysis centers that you can go to. And HMO premiums tend to be high. HMOs also have more requirements in terms of getting approved referrals to specialists, in getting favorable dialysis schedules, in pre-approvals for testing and treatment. So in the insurance world, we call it having a gatekeeper. If the facility is not an HMO contracted with that insurance company, then technically you have no coverage to use that facility. Yes, there are a few exceptions that are made. Now, PPO, on the other hand, does not have those kinds of limitations, and referrals and authorizations are less frequent. You have benefits whether you use a clinic or facility that is contracted to your insurance company or not. However, you're going to have much better benefits if you stay in what we call the network. In other words, you visit a contracted doctor or facility. Always try to stay in network if you can, and always check out who the providers are and who they're contracted with before you go to see them. Let's look at employer group coverage now in a little bit more detail. As I said, prior medical history and current medical conditions are totally irrelevant, have no bearing on your obtaining or being accepted into a group medical plan. Okay? You're also in a much better position should you lose this coverage. I know that is a concern to many of you. Let's assume you're under a group plan and for some reason you lose it. You get laid off, you decide to leave that employer, you get divorced and lose the coverage you had through a spouse, you go out on disability, whatever the case might be, you typically are going to be eligible for what's called COBRA, and usually in California it's 36 months. Now, COBRA is not going to be available to you if the employer chooses to close down the group plan or the employer closes the company. There must be a group plan in existence for you to extend your COBRA offer. So what happens if you've been on a group plan, you've gone on COBRA, you've exhausted your time period on COBRA, or you couldn't get COBRA because there was no group available? What's going to happen to you now? You go file for an individual plan. You're going to come under what's called guarantee issue or part of the HIPAA law. This basically says that if you've been on a group, you've exhausted or could not have COBRA, you have filed for an individual plan and been declined because of your medical history, that insurance company has to issue you what's called a guaranteed issue plan. Every company has them. Typically, they're always going to be PPO plans, although there are a few HMOs. They will usually have higher deductibles, maybe $1,500, $2,000, and they're going to have a higher premium. But they are good PPO plans, just like any other PPO plan that's out there. So rest assured that if you're in a group or you're coming off a group, you are not in great jeopardy of not having coverage. It's the cost that may be the factor, and so often is. One other important aspect of group coverage is that every year on your anniversary month of the plan, most plans are going to give you the opportunity to change plans. So this could be very important to you if you have been carrying lesser benefits. You now find yourself facing potentially more treatment, testing, higher expenses. This is an opportunity for you to enrich your benefits. But remember, this can only be done on the anniversary month of the plan, once a year, if your plan allows it. So in that case, I would definitely check with your employer and find out what your situation is, because you don't want to miss that window if it's important to you. Individual coverage is treated somewhat differently. First of all, you have to qualify for it. So if you file an application and you are not, you have medical history, you can be declined. But once you have a plan, it cannot be taken away from you, unless you fail to pay the premium, of course. So every major insurance company is going to offer individual plans. Also, plans cannot raise the premiums just based on you, or based on your history. When prices increase, they go up across the board. They may increase it based on an age bracket, it may be based on a particular plan, or the company may do it in a particular geographical area. But they're not picking on you as the patient or the client, as one of my clients accused me of last week. I had to convince him that it wasn't his history that had done this. One of the downsides of an individual plan is that it is not easy to switch from one plan to another like you can in the group world. So if you already have a medical condition or you have history, and especially if you now want richer benefits than those you currently have, it's not going to be easy to qualify to get a plan, depending on, of course, your history. Nor is it easy to switch from one insurance company to another, because you file an application and you start the process of requalifying all over. The toughest situation is when you don't have an employer plan and you don't have or cannot qualify for an individual plan. And that's the gap that we really struggle to find some coverage for clients. Assuming you don't qualify for Medicare or Medi-Cal, what options do you have? There is a program now called Major Risk that was introduced a few years ago. It's written by private insurance companies, but it is overseen by the state. It's actually a pool concept. It has a maximum of 10,000 participants, and at times there are waiting lists to get onto it. The coverage is good PPO or HMO coverage, although the annual and lifetime benefits are not very high. That's the downside of it. And the premiums, of course, are high. The basic message is that there is coverage out there for nearly everyone who needs it. Let's look at some choices now that if you are on Medicare, what do you have? If you're already over 65 and therefore you're on Medicare, the issue becomes what kind of supplement plan should you have? The supplement plan picks up the pieces of both inpatient and outpatient that Medicare doesn't pay for. So if you're on an employer plan, usually Medicare is going to become primary when you turn 65. Depends somewhat on the size of the company you work for, but in general it will become primary. So the group plan then becomes your supplement and picks up the gaps of Medicare. My general comment would be if you have a group plan, and if you're under or over 65, keep it as your Medicare supplement, mainly because your drug coverage is usually going to be so much better on a group plan. And again, if you have a chance to change plans once a year, get a plan with a good drug coverage, as I know you're going to need it. If you're under 65, but you still qualify for Medicare, I think Christine's going to talk about that in a few moments, and you have an individual plan, you have a slightly harder choice to make. You can keep your individual plan even though you go on Medicare and let it become your Medicare supplement. Now, it also will probably have better drug coverage in it than if you go on what's now called the Part D Medicare drug plan. So you need to look at that very carefully. My other concern is if you give up an individual plan because you have Medicare for a few years, then you lose your Medicare, because I'm talking under 65 now. You will probably not get your individual plan back if you let it lapse, because based on medical history, you probably wouldn't qualify for it. So there are some difficult choices there to make. Likewise, if you turn 65 and you go on Medicare and you have an individual plan prior to 65, you can still keep that individual plan. You don't have to give it up for a Medicare supplement. And again, the choice might be which has the better drug coverage, because that, I think, is going to be the major issue for some of you with your kidney issues. You might be better off keeping that individual plan. You need to look at the size of the deductibles, the co-pays, and the drug coverage. If you leave a group plan or you leave an individual plan and choose to go onto a Medicare supplement, you are on what we call guaranteed issue. So from the time you go on Medicare, you have a certain window within which you can move to a supplement, and it has to be given to you. Again, medical history is irrelevant, and there's a window of time there. Been talking with various insurance companies about their handling of kidney disease. Other than looking at your own coverage and trying to see how it might fit your future needs, there's really not a lot different between the treatment of kidney disease versus any other chronic or major disease, especially, we'll say, cardiac problems. Some of your medications you take may need pre-authorization. Some companies require authorization for certain dialysis centers, and most of them will require pre-authorization for the surgery, even though it's considered general surgery. So that may be an issue that has to be dealt with to get authorizations. This can be a vast and somewhat daunting subject, as I know most of you know, and like most things in our lives, it takes some study and some homework. If you're potentially facing some extensive and expensive treatment, my best advice is to seek advice. If there's ever time to be in charge, be assertive and manage your own health care, I would say you're probably in it right now or approaching it. If you're on a group plan, talk to your HR staff at your employer or whoever handles your employee benefits. Okay? Make sure you understand what benefits you have. Make sure you understand when you can make changes to that plan. And if they don't have the answers, ask either who was the agent that wrote that group plan for them, or call the company direct, and you've all got a phone number on your ID card. But ask those questions and make sure you know what you have. The same goes for individual plans. Make sure you know ahead of time what your benefits are and what would it take to change that plan if you wanted to. Make sure you understand the benefits for your condition. You can do this by reading the contract. I don't recommend it. It's the best bedtime sleeping pill available. If anybody wants a contract, I'll get you one to read if you're having a problem sleeping. But I would either call your agent or, again, call the company direct. That's what agents are there for. Premiums are the same whether you use an agent or you go direct to the company. The difference is the agent doesn't work for your company. The agent is your advocate. So if you don't have one, I would sincerely suggest that you find someone to talk to or get one on your behalf to advocate for you. Many insurance companies have what they call care management departments, and they're there just to do that, to help you through some of this process, and especially for chronic and serious conditions. I talked with several before today's presentation and got their thoughts on this, and most of them I found very helpful, very compassionate, very knowledgeable, and very willing to walk me through the process of what all it takes. So I hope this has helped a little in advising you what's out there in the insurance world. allay some of your fears about it, and of course how it might apply to your situation. I'd be happy to take questions after, happy if anybody wants to consult and spend some time and go through their plans. It's a vast subject. As I said, every plan is different, and there are hundreds of them out there, but happy to talk to you about them. But I hope this helped a little bit of the overview of what's out there and some of the considerations that you need to make. Okay.
Hi, so I'm Christine. I'm just here as a HICAP counselor. I just want to make sure that you know that I don't work for Medicare, because the way that HICAP is administered, and I like show and tell a lot. I like for people to participate. So what I wanted you to go through is this packet that I gave you. And so I'm not going to go through everything with you. If you don't have a packet, there's some in the back table. There's maybe somebody could pass them out there in the back. But the first thing, I just wanted to make sure that you understand what HICAP is. HICAP is the Health Insurance Counseling and Advocacy Program. We basically are a program that helps people on Medicare understand Medicare, which is greatly needed, because Medicare, as you know, can be confusing. It's a great program, Medicare, but there's a lot of ins and outs of Medicare that you have to be aware of, a lot of rules and regulations. Every program, every county in the state of California has to have a HICAP program. It's mandated by the federal government. We're part of the state health insurance and assistance program. So every so every state has to have what we call a state health insurance and assistance program, because the federal government realized that people really needed help understanding Medicare. So each state has to have a program, and instead of calling it SHIP, we call it HICAP in California, because we started the HICAP program in 1986. California people here, just that were healthcare advocates, just really saw the need for this type of help. So I work out of the San Mateo office. We have basically 25 counselors. And what our HICAP counselors do is they basically go into different community centers, senior centers, throughout the San Mateo County area. And what you do is you call 1-800-HICAP. It's right down at the bottom of the page, on the pink page. And what you do is we'll set up an appointment with a HICAP counselor. Now, not all our counselors are experts in end-stage renal disease. I'm not an expert in end-stage renal disease. But what we'll do is when we see that we have a client on Medicare that has end-stage renal disease, we'll gather our resources, we'll talk to people on Medicare, so that when you come to that meeting, we'll try to have the best information for you on how Medicare works with your end-stage renal disease. Because it's a little bit different, especially when you're under 65. You don't have all the guaranteed issues that you do when you're 65. But again, we serve Medicare beneficiaries. We also, if you're a person that's mother is over 65 and your mother or father doesn't understand Medicare, we're happy to just make an appointment with you so you can go and educate your parents. We really see how people are really helping us nowadays, because Medicare is so confusing that people, family members are really helping people understand Medicare, their aunts and uncles, their parents. So we really appreciate your help. And I'm just going to basically just finish with that pink sheet. The next sheet is California Health Advocates. California Health Advocates is our sister organization. They're the people that make all these great fact sheets. The thing about HICAP is I can talk to you about Medicare, I can tell you the rules and regulations, but you're not going to remember a word that I said afterwards. And so this is why we love these fact sheets, because when we provide one-to-one counseling, we give you all the specific fact sheets so that later, when you go home, you go, oh God, what did she say? I don't remember. You have this fact sheet, so then that way you review these, and later you can look and call us back and ask us a question with that question that you have. So our agency, California Health Advocates, develops all these fact sheets for us. They have a lot of different public meetings. Again, you can just go on their website. It's californiahealthadvocates.org, and basically they're happy to share all the Medicare fact sheets with you and all the information that we have. What I wanted to just talk to you about Medicare is this section here. Just turn this over. Again, Medicare Medicare, there's 4 parts of Medicare. There's Part A, which is basically, we call it institutional care. It's more the hospitalization. Medicare Part A covers you when you're in the hospital, skilled nursing, and under hospice benefits. And I'm going to go into more detail about that. Part B is what we call the medical. It's not Medi-Cal. And people sometimes call us up and say, we're on Medi-Cal. And I go, I have Medi-Cal Part B. Well, it's not Medi-Cal, it's medical. And Part B is the medical insurance, it's the doctors, your physical therapists, your ambulances, your tests, shots, durable medical equipment, home care services, or under Part B of Medicare. Part C is what Medicare calls a Medicare Advantage plan. What happens is when you have a Medicare Advantage plan, you have to have Medicare Part A and B to join a Medicare Advantage plan. And the Medicare Advantage plans are like Kaiser, Secure Horizons. We have a lot of new Medicare Advantage plans, which are called health maintenance organizations. Some are basically private fee-for-service organizations. So if you basically need a lot of help when you're looking at all the different Medicare Advantage plans, and I basically don't have the Medicare Advantage plans with me today, I can basically, our fact sheets, I can basically talk to you later, and if you want one of those, I'm happy to give it to you. But basically, with Medicare Advantage, you're contracting with a certain group of doctors, the Medicare Advantage plan does, and you have to basically go within their guidelines. They'll have different copays and deductibles too, and I'll basically, when you talk to me later, I'm happy to send some of those fact sheets to you that have the different copays and deductibles. And now we have the new Medicare Part D, which is Medicare's drug benefit. So basically, I have some more information in the back too, but it has an initial coverage period, it has coverage gaps. I could go into more detail, but I want to because you're not going to remember anything I said about it. So when we talk later, you can come up and talk to me if you have questions about Part D, or you can just go back and look at the fact sheet. But I just wanted to make sure you're aware of that. So how you supplement Medicare. Now I would just turn this other sheet over. There's different ways to supplement your Medicare. If you have an employer group health plan and you're under 65 or you're over 65 and basically you're still working, you're basically, you can still sign up for Medicare, but you don't have to sign up for Part B at that time, because usually what happens is you have your employer group health plan is supplementing your Medicare Part A. So you have like what we call a special enrollment, that when you leave that job, you can later sign up for Medicare Part B as in boy. There's also Medigap supplemental plans. Deanna talked a little bit about it. I have a sheet in the back too that explains all the different supplemental plans. Basically, the Medicare supplemental plans, you have to have Medicare Part A and B, and what it does is it supplements the copays and deductibles that Medicare doesn't cover. Again, I talked a little bit about the Medicare Managed Care. You can get a Medicare Advantage plan. Some of them have drug coverage, some don't. So it can be very confusing because you can think you signed up for a Medicare Advantage plan, you go to the drugstore, and that Medicare Advantage plan doesn't have drug coverage. So it's just something that someone forgot to tell you. It happens, and we deal with these type of problems all the time. So that's why before you do any Medicare decision, basically, come see us, make an appointment with HICAP so we can go through all those different rules and regulations with you. If you have a low income, you can supplement your Medicare by being eligible for Medi-Cal. You basically go down to the Human Resources office within the county, and basically you can apply for Medi-Cal, the Medi-Cal offices. We have different fact sheets about income and assets. Basically, your assets have to be less than $2,000 if you're a single person, less than $3,000 if you're a married couple. You have to have a certain monthly income. I can't think of it right now. I don't have my fact sheet. But anyways, what you would do is just go down to the Medi-Cal office and apply for Medi-Cal and low-income programs. And then if you have let's say you're a former veteran of World War II, and you just say, well, I just want to go to the VA hospital, you can have your Medicare A and B, and then your veterans benefits will supplement your Medicare. But you have to be careful sometimes with veterans benefits because sometimes if you have an emergency and you can't get to the VA hospital, you have to make sure that the VA gives you that authorization. The VA is usually very good about it, but we also, what our program does is we hear a lot of the problems, and so I just want to make sure that just like Deanna was saying, you have to really know your health care nowadays. There aren't people that are just going to be helping you as much. I mean, people want to help you, but your healthcare decisions are your private decisions. You've got to decide what type of healthcare is best for you. Because people say that to us all the time. Can you tell me what I should choose? I can't. Because HICAP is unbiased. We can't tell people what to do. But we can explain what your choices and your options are. But you've got to make your own decision because we're all individuals. What's important to someone isn't important to another person. So we're not trying not to help you. It's just that you really just have to try to make your own decisions regarding your health care. And also there's TRICARE benefits. TRICARE benefits are for retired military personnel that have been in the service more than 20 years. And TRICARE benefits are great. They supplement your Medicare too. I just wanted to go through a little bit why you need health insurance when you're on Medicare, because if you just turn over, it says Medicare Overview. If you turn it over and look right here, it says Summary of Medicare Benefits and Cost Savings for 2008. Well, people think, well, I'm on Medicare. I don't need to worry about anything. Medicare covers everything. I don't need any other health insurance. Well, that's not true. There are some people that basically don't get other health insurance, but if you don't get the other health insurance, where it says you pay, you're responsible for those costs. Meaning, when you first go in the hospital, you come into Sequoia Hospital, when you first get admitted into the hospital, you go upstairs, well, you're responsible under Medicare for a $1,000 24 deductible. So right there, if you don't have health insurance, that's to come out of your own pocket. That's your co-payment for being hospitalized. If you stay in the hospital over 60 days, days 61 through 90, you have a $256 per day co-payment. Beyond 90 days, you have these lifetime 60 reserve days, and so that's $512 co-payment that you would basically have to pay out. What I just want to talk to you about the 60 reserve days is it's like a bank. Those 60 days are like a bank. So if you're in the hospital 91 days, the next time you go into the hospital, your next benefit period, you only have 59 reserve days because that's just like a little bank, which we call the reserve days. And I want to make sure you understand about benefit periods too, because you can say, well, I've been in the hospital this month, and you go in about 3 months. Well, I've already paid my deductible. Well, no, you're basically, it's a new visit to the hospital because basically a new benefit period begins when you have not had any services for 60 days in a row. So you could be in the same benefit period for 120 days. You go in the hospital, you go out the hospital. So as long as you don't have any, when you don't have any services for 60 days, that's when you start a new benefit period. So I just want to make sure you understand that because that is something I don't think people do understand, the fact that you could pay out this 1,024 a couple times during a year. And so I just wanted to make sure you understand that regarding what a benefit period is. As far as skilled nursing facility, if you ever went into a skilled nursing facility, you need to have a 3-day hospitalization. That means 3 full days in the hospital. Because in order for Medicare to cover under your skilled nursing benefit, you've had to have been in the hospital those 3 days. And then if you do get transferred to a skilled nursing facility, you need to require that skilled care. You can't just say, well, there's no one home to help me, or my daughter can't come over to help me. If you don't require that skilled care where you need a registered nurse, a physical therapist, basically a speech therapist and an occupational therapist within a skilled nursing facility, you basically won't have your skilled nursing benefit under Medicare, meaning you'll have to start paying out of your own pocket right away for any type of skilled nursing care. Medicare covers days 1 through 20, as long as you require the skilled care. Days 21 through 100, you have a co-payment of $128 per day. Anything after 100 days, basically Medicare doesn't cover anything unless you have long-term care insurance, and I can basically talk to you some other time about long-term care insurance. I'm not going to talk to you about that. But I'm also a long-term care insurance counselor, so if you ever wanted to know how your long-term care insurance policy works with your Medicare, you can just, again, call our office. Again, I'm just going to go pretty quickly. I don't want to take, I have other points, but then the home health care, hospice, it's pretty self-explanatory. Medicare doesn't cover the first 3 pints of blood when you first go in the hospital. The next thing is the Part B. If you basically have worked at least 10 years and paid into 40 quarters into Social Security, your Medicare Part A is free, but your Part B is basically a monthly premium unless you are eligible for low-income programs. Your Part B costs $96.40 a month. So basically, you have to pay that out to Social Security. Most of the time it's deducted from your Social Security check because people get on Medicare before they sometimes reach their retirement age nowadays. Medicare is now billing people on a quarterly basis. But it's just important that you know that your monthly premium is $96.40. And if you make more than $82,000 as a single person and $164,000 as a married person, as you can see, now the Medicare Part B premiums are basically based on income. So if your income is over the $82,000, $164,000 for couples, you're going to pay the $122.20. So the way that Congress felt is that you could help by putting some more of your money into the healthcare costs. So this was something that they decided in, I think it was in 2006, so it's been going on the last couple of years. Again, Medicare has an annual deductible under Part B as in boy. It's $135 a year, so if you didn't have any other health insurance, your doctor bill was $235, you pay that first $135, then Medicare will cover that $100. But again, Medicare is only going to cover at 80% of the approved amount for your physician costs. So again, when you look under physician costs, Medicare covers that 80%. You're responsible for that other 20% out of your own pocket. Again, this is why people get health insurance, because they say, well, I don't want to pay all these different copays and deductibles. So that's why when we go back to the yellow sheet, we decide which one of these different insurances are you eligible for. And again, it's going to be different for people under 65 with end-stage renal disease versus people over 65. The other thing I just wanted to talk about is Medicare enrollment periods. Medicare enrollment periods. Oh, boy, it's confusing nowadays because there's certain times that you can join get certain insurances, certain times you can't. And so I just wanted to make sure. This is our newest fact sheet. We were waiting for this fact sheet for so long. It's called the Medicare enrollment periods. I get so excited when I see it because it's just such a great sheet. Because at last, I have a sheet that can just explain to people. Because I used to explain it and they just look at me cross-eyed. And now I feel like I have something to give to someone so they can understand the Medicare enrollment period. Because there's the initial enrollment period. When you first get on Medicare, your initial enrollment period is 7 months. Now, did you know this? Does anybody here, did anybody know that? Or when they first got into Medicare? Yeah, see, I think it's somehow it doesn't get out to people. So what it is, before you turn 65, you have the first 3 months before you turn 65. You have the month you turn 65, and then 3 months afterwards. That's your 7-month enrollment period where you can sign up for Medicare get a Medicare supplemental plan or a Medicare Advantage plan, and also sign up for Medicare Part D. But you don't want to wait those. You don't want to wait those 3 months after you turn 65 because you want to have health care insurance when you turn 65. Because of the fact that something happens to you that when you turn 65, even though you have that 3 more months under your initial enrollment period, if you fall down or something, you won't have anything to supplement your Medicare. So we always tell people that really that about 2 months before you turn 65, you should really be looking at a different insurance coverage. Because usually it takes time for all this enrollment to happen. It isn't just like, I roll on the 30th of June and I get my benefits July 1st. It doesn't work like that. We tell people that you should definitely enroll the beginning of the month before you're going to get a supplemental or a Medicare Advantage plan. So you should just basically do all the enrollment process for June 1st if you want something by June 1st, if you want to have insurance by July 1st. The other things about the initial enrollment period is just turn over this initial enrollment period for Part B too. So if you have that 7-month enrollment period and somehow you didn't enroll in your last 7th month, well, you're not able to enroll then. So let's say your 7th month was July 1st. That was the end of your initial enrollment period. Well, you can't enroll in Part B until January 31st, through January 1st through March 31st the following year. You aren't eligible to enroll till then, and then it's not going to start till July 1st of that year. So it's very important that if you miss your initial enrollment period, that your general election period, during that period you'll have to enroll, as I said, between January and March, and then it will be effective starting July 1st. There's an initial enrollment period for Part D, which is November 15th through December 31st. And again, just review that, because I just wanted to get into this yellow page. And then you should, how many more minutes do I have? Okay, but I'm trying to be fast, but I still don't want everyone, because again, I don't feel I'm an expert on stage renal disease. I think the other people here are, that basically work with that population. So also, unless they don't agree with me, I think they're also a great resource for what Medicare pays and what Medicare doesn't cover. Wouldn't you say that, you work with end-stage renal disease? Because they're working with you every day. So I guess, there's just great, people, great assets for you to also talk to about, what you should do also regarding your health insurance. But as far as eligibility, these are basically Medicare guidelines. Everything I talk about I get from Medicare. Medicare is the ruler of Medicare. So basically we get all our information from Medicare. We do most of our education with Medicare. Every August I go to train the trainer. There's usually about 200 people, and we all learn what's new in Medicare. So people also, sometimes they let people from the public come. If you're a head of some organization, you should also try to see. It's done by Region 9 in San Francisco. So Region 9 is our contact for Medicare in San Francisco. And so if you want more information about that, just talk to me afterwards. But again, not all individuals at end stage are eligible for Medicare. I'm on the orange sheet. In addition to end stage, one of the following criteria must be met. The individual must meet the required work credits under Social Security, railroad retirement, or as a government employee. The individual receiving Social Security or railroad benefits. The individual is the spouse or dependent child of a person who has met the required work credits or is receiving Social Security or railroad retirement benefits. So again, there's different effective dates, and I don't know if I need to go through all them, but I just want to make sure that you understand there's a different, like if you have hemodialysis, Medicare is effective the 4th month of treatment. If it's begun in May, Medicare becomes effective August 1st. So it's just, these are certain guidelines that you need to understand regarding Medicare. Home self-dialysis, Medicare is effective the 1st month of treatment if the individual takes part in a training program through a Medicare certified training facility. Home self-training is begun within the first 3 months of treatment. So you have to decide with your dialysis coordinators and the specialists what is it that you want to do. Some people can do home dialysis, some can't. So that's why it's important that you work closely with the people helping you with your end-stage renal disease. And then with transplant, Medicare is effective the month the individual is admitted to a Medicare certified hospital for a kidney transplant or for health care needed prior to a transplant. If the transplant takes place the same month within the following 2 months. I mean, this is a lot of verbiage, It can be confusing, So, I even know myself, I have to really, when I read things under Medicare, I have to really, sit there and study it for a minute. So, I just want you to realize that there's people there to help you, that even though I'm sharing all this information with you, I'm not expecting that you're going to basically know all of this afterwards. The other thing, I was just giving some specifics for employer group health plans regarding end-stage renal disease. We have some great fact sheets. It's called Medicare and People with Disabilities, an Overview. It just gives you some information regarding your different protections, your rights to health care today. And the one thing that it's going to be happening, which I didn't have, I kept wondering, there's a special fact sheet just now that we've developed for people with end-stage renal disease, and it's under development. So it's not done yet by the California Health Advocates. So I just wanted to let you know. And then in the back, I have some information about Medicare Advantage plans. The one thing I just want to make sure you know about Medicare Advantage plans when you have end-stage renal disease, especially when you're under 65. I had a case where a man lived in Contra Costa County, and he was moving to San Mateo County to live with his sister because his sister was going to help him. Well, what happens is he had a Medicare Advantage plan. Because he goes to another county where that Medicare Advantage plan doesn't have, isn't basically within that county, he lost his health care coverage. So you have to be very, very careful. I mean, you'd say, wow, what's this? But it's really, things like this happen, the way that Medicare works, because if you've already had basically, let's say I was with Kaiser before I got end-stage renal disease, and then basically I got on Kaiser Senior Advantage later, and I moved into another county that doesn't have Kaiser Senior Advantage. Years ago, Lake County didn't have Kaiser Senior Advantage. Well, I wouldn't be able to transfer my Kaiser. I would not have anything then to supplement my Medicare unless, I was able to get some type of Medicare supplemental plan, which we call Medigap. So you really have to look at things when you're making changes in your life, even moving, things like that, because there's a lot of rules and regulations regarding if you're going to have those guaranteed issued rights when you move to another area. There's a lot of guaranteed issued rights, and again, it's very specific. I'm not trying to scare you or anything, but I just wanted to make sure that you know that before you basically do make some changes in where you live, you've got to really look at, will I be able to carry my health care insurance with me? And we'll be very happy to help you with basically defining whether or not you can. And then the last thing is I just want to show, these are the different Medigap plans. I have this information in the back. These are what we call supplemental plans. There's supplemental plans go from A through L. Basically, they supplement the co-pays and deductibles that Medicare doesn't cover. These supplemental plans can run you for like $100 to $150. And sorry to say, people under 65, they pay a lot more for supplemental plans. For some reason, insurance rates are always a lot higher for people with disabilities. I mean, I don't think it's right, and I wish it wasn't, but it's the reality that for some reason that your insurance is always, your premiums are usually much higher, so especially when you're working with Medicare. And then the last thing I just wanted to talk to you about was Medicare Part D. Basically, I have this information in the back, but these are all the different Medicare Part D plans. Right here on the green sheet, these are what we call the standalone plans. These aren't the plans that work with, let's say, Kaiser or Medicare Advantage plan. What I want to say to you about the Part D plans and your prescription drug coverage, what you should do, don't look at what the premium is, look at what the formulary is. It's very important. When you sign up for a Part D plan, there's basically, you say, well, this one, it's only like, let's say $18.50. And you think, well, that's a great plan. I only have to pay $18.50. But the thing is, maybe when you go to get that drug, it's not in the formulary within that plan. So it's important that whenever you look at Part D plans, give us a call. What we'll do is we go on Medicare's website. We go right on the website, we punch in your medications, and then what we do is we show you the 3 plans that are the lowest cost plans that cover your medications. We do that especially between November 15th and December 31st. It's one of our craziest periods, but if you can do that yourself at home, that's great, but you won't know the new Part D plans until, maybe we'll get them November 10th, but sometimes we don't get them November 10th, but, so then we just work as quickly as we can in getting these new, fact sheets for you of all the different Part D plans. But it's just important that you know that Part D is a great plan, but you're going to have a lot of co-pays and deductibles. You have what we call we call it the donut hole. Medicare doesn't like us to call it that, so we call it the coverage gap. And so, that's where you basically in the coverage gap, you're responsible. You must cover at least $3,216 worth of your own drugs. So I think, just as Deanna was saying, you really got to look, are you in a better situation if you keep your individual health plan or your employer group health plan? Maybe you want to work a couple more years or something, because these co-pays and deductibles and coverage gaps can really add up, to the point where, maybe it's better for you to work a little bit longer or keep that individual plan, even though the premium's higher, but maybe they have a better, what we'd say, like prescription drug plan. So again, I'm trying to do this pretty quickly, and again, there's so much information about Medicare. I mean, I get overwhelmed by it myself. I mean, I feel like I know it, but I'm just saying, there's always changing, and you just have to realize that we're here to help you, and we really want to share the information that we have, and that if you have any questions regarding Medicare, just give us a call at HICAP. You can also call 1-800-MEDICARE. Nothing against them, but sometimes they don't have all the information that we do at HICAP. Because we have a long history within HICAP. We've been doing this program for over 22 years, and this is 30. Now I got to add right, yeah, so 22 years. So it's important that we have that background, and Medicare is important too. But I would say whenever you talk to anyone in Medicare, and they know we say this, so it's no news to them. I would talk to about 2 or 3 people and see if you get the same answer, because it's true. You really you call 1-800-MEDICARE and they'll give you an answer and then another answer. So I would just advise everyone to call a couple of people, and then then give us a call and then talk to your basically, like I said, these specialists here. I mean, they're great resources for you. They really know what Medicare covers and what Medicare doesn't. So I thank you very much.
Hi, I'm going to kind of keep this short and brief. I think both Deanna and Christine gave a great in-depth overview of all the different health plans that are available and how they work in conjunction with each other. So what I'm going to do is kind of give you an overview of what we do at Stanford. And I understand that many of you may not be Stanford patients, and we do deal with the transplant population. But be assured, I do have cards in the back. If anybody has questions of me, after we leave today, please feel free to call me. What I try to do, and I've made this something when I interview my staff when they're coming on board, is to make sure that they have a passion for what they do. Because if you don't have a passion in this business, you really don't have any business being here, because what we do is to be there for both of our hospital, our physicians, and our patients. So, and part of that entails helping the families. And what we find is when a patient first comes to us, we're with them from the beginning all the way through, and post-transplant, and until you move out of the area or you don't want anything to do with us anymore. So we start at the initial referral. We verify benefits for patients. We get all authorizations in place for the transplant services. And with kidney patients, some of you may not be aware, but what happens with the evaluation is that goes into a little bucket we call kidney acquisition. So really nothing gets billed out for a patient's evaluation. So if any of you, start getting bills when you're going through your evaluation, you really shouldn't. And that wouldn't be with just Stanford, but it would be with any other facility, UCSF, CPMC, any place you go. Your evaluation services go into this little bucket, and then they get billed out at the time of transplant. So we do verify benefits. We make sure authorizations are in place, because even though nothing is going to your health plan, we need to make sure that you're going to be able to see us. And what happens sometimes is somebody will say, oh, yep, this is fine, it goes into acquisition. Well, that's all well and good, but if your health plan turns around and says, well, hey, we don't have a contract, that's not going to work. You've already started with us, and we put you in a bad position. So we start from the beginning. We move through the process with you. And what happens is we may find out in the beginning that you don't have enough benefits. So maybe you don't have your Part D prescription coverage in place. And have a very good example from recently. We had a patient that came to us just in December, didn't have a Part D plan, very sick, but had had their Medicare since 2001. The Part D plans went into effect 2005. Nobody has ever counseled this patient in getting a prescription plan through their Medicare. So we scrambled the last few days of the year, showing him the different plans that were available, what the options were, and getting him signed up for coverage. He just had a transplant this last month. So all's well and good. Now the thing that comes into play, as many of you know, is with the Part D prescription plan, there is that huge coverage gap, the donut hole. What happens with the transplant patients is that hits you 1 month. So the month you have your transplant is typically, if you haven't hit that coverage gap, you will hit it that month of transplant. And that is very frightening for some people, because they don't really understand, and like Christine said, we can tell you over and over again, we can provide you with written materials. It's not going to sink in until you get that bill, Or somebody says, hey, you're leaving the hospital today. Can you give us $4,000? And that's very scary. So we try to give patients all this information up front. When we do the initial benefit verification, we give you a financial packet. It tells you about who we are, when you should contact us, which would, in our case, we'd love you to always contact us. If you have a question and you're not sure who to go to, come to us. If we can't answer it, we'll get you to the right person. And a lot of times, it may seem like it's a silly question, but we would rather you come and ask us. We'll find out the information for you. We also provide you with a fundraising packet because a lot of times you may not be eligible for additional coverage. So we try to get people to start fundraising from the start. We do in some cases have people that are not able to fundraise until after transplant. That's okay, it still works. And we'll guide you through the process and the different organizations to go to. We also work with our social workers in doing patient assistance programs for prescriptions. Anybody out here use patient assistance, or if you don't want to raise your hand, that's okay. So there are patient assistance programs that are available if you can afford medications like Valsite, which is prophylactic medication post-transplant. It's about $5,000 a month. No. Depends on the dose you're on, but what we're finding is
I had no idea.
it's very expensive. So there is a pharmaceutical program available through the manufacturer, and we can get those medications depending on your financial status for free. So that is something that we do for you. And I do have some packets at the back. There are some packets from Medicare for kidney patients, and then also our fundraising and our financial packet. So please feel free to take those. Like I say, if you're not a Stanford patient, you're not a transplant patient, you can call us because we don't mind taking calls. So we work with you through the whole process. If you don't have secondary coverage to Medicare, we'll work through the process to find you some coverage that will work for you. Every once in a while, there's something that we can't do. We do also have financial assistance that is available through the hospital, and that's a packet that we will help you complete. It goes to the hospital, and it will cover services after Medicare or to cover co-pays and deductibles and so forth after your insurance. It's something that does work just through Stanford, so you can't go out and try to use it somewhere else, or to use it, unfortunately, for prescriptions. We no longer have an outpatient pharmacy, so that is the one area that it does not work for. But we do try to find whatever might be available for you within the community or within the hospital. We do find that some patients can get VA benefits. Some already have VA benefits, and we do get referrals for patients with VA coverage. Unfortunately, what we then have to do is find additional coverage for you. Because even though with a kidney patient you have VA benefits and they do cover those services, they don't cover them at our facility. And typically those are just covered through the VA. So we will work with you directly to obtain Medicare benefits, Medicaid, see if you have commercial insurance that you can work with through our facility. I also have found through the years that what we tend to do is, I sit down a lot of times with families when they're changing coverage, and we would prefer to talk to you directly if you're going to change insurance coverage before you make the change. So that's one thing that's on our financial packet. Please call us before you make an employer change insurance coverage. And that is not always in your, it's not something that you're able to make that choice. You may only be offered Kaiser. So then we have to talk about, okay, if you have Kaiser, can we see you anymore? What can we do? Would it be beneficial for you to go somewhere else? What can we help you with? But you may be offered 3 or 4 plans to choose from. And I would rather sit down and talk to you and go through the plan booklets with you, or on my own. I will take them home and I will go through and I'll mark out all the options for you and give you an outline of which plan we think would be best for you and the reasons why. And we do that, and we do it for your family as well. So we're not going to just choose the benefits that are going to be good for you as a transplant patient. We're going to help you choose the benefits that are good for you and your family. Because you're all in this together and we're in it with you. So we're going to help you through that process. The other thing that we do is with the new Medicare D plans. About mid-October to mid-November, I sit down with all the different plans that are available for the new year. And pretty much every year since they started, there have been new plans. Some have changed, some have just gone by the wayside, and then there are new plans. So what I do is I go through and I take all of our transplant medications and I plug them into the website, and it's not going to work for everybody because some people are on a few different medications. So, but what we do is, in general, all the transplant medications, we will go through and we will pull out the best plans for our transplant patients. And we will outline the benefits, we'll outline the co-pays, and we'll help you choose a new plan for the year. What happened, interesting incident this last year, is they stopped covering brand medications during the coverage gap. So there was one plan last year that covered both generic and brand. This year there's none. So I'm hoping that come November there is going to be a little change in that. But I think what happened is people realized, or the plans realized, that they were losing money when they were covering the brand medications. But we're hoping that something will come to fruition and we'll have that coverage back again. But that is something that we will try to do too. We'll work through the plans for you. Okay, and that's it.